So thanks very much. Is that working? Yeah. Thanks very much to the organisers. This has been a fantastic conference so far. I've learned so much, and it's just great to see so many people interested in the emerging issue of overdiagnosis, which I actually see as the greatest threat to the sustainability of healthcare systems in the world. In regards to that, I'll declare two conflicts of interest. One is with the Healthcare Sustainability Partnership, which is aimed at looking at these sorts of issues and quantifying them and looking at how to change a sort of research arm of that. The screen keeps disappearing on me. Look at that one. The Wiser Healthcare Collaboration, which is a group of Australian researchers working in this area, and they're both funded to look at this issue. I should point out that Wiser was actually a name that we just made up. We have no evidence that we're wiser, so it may be an overdiagnosis. I just thought you knew. So just the size of the problem, first of all. This is some of the Australian data on this. So you've just heard about thyroid cancer. In Australia, it's a 3-to-1 plus a threefold increase that we've seen. So now we have about 3 out of 4 cases being overdiagnosed with thyroid cancer. With breast cancer, it's about 1.4, a 40% increase. And that's from the screening programs. Renal cancer is incidentally detected ones. There's no screening program for renal cancers, but we're getting this increase in them from incidentally detected ones when people are doing imaging of the abdomen for other reasons. And prostate, even though there's no formal screening program in Australia, there's a lot of informal screening. About 50% of men in Australia aged between 50 and 70 have had a PSA at some stage. So that's led to this twofold increase. Unfortunately, if we had higher compliance, it would be even worse than that. So we've heard a lot about cancer, but of course this is, and the consequences of that, the increased surgery, chemotherapy and follow-up, as we've just heard for thyroid cancer. But it occurs in other areas. Our Monash partners, led by Rochelle Bookbinder, are looking at musculoskeletal, as is Chris Marr at the University of Sydney. And there's a lot of potential for overdiagnosis because of the asymptomatic lesions that we can discover on imaging. So, for example, for people even younger than me, in fact, 50 to 60, if you look at their shoulders, you get rotator cuff tears of about 13%. If you look at my back, a disc bulge of 78% or disc protrusion of 28%, meniscal damage 20%, and any abnormality 84%. And that's all asymptomatic people. It might be even worse in symptomatic people. Okay, what can we do about this? So there's lots of things that we could do, and we've heard it during the session and during other sessions, some of those things. I'm going to focus on just the regulators and health authorities and what they may potentially do about this. So just to remember what I'm going to say in this, because this session is about the policymakers and regulators, that there are lots of other things we can do at clinical levels, public levels, through the media, etc. This is just one potential approach. So I'm going to talk about it in particular through this idea of the flow of things, of doing the test, defining or interpreting the outcome of the test, and then what we talk to the patient about. I'm actually not going to cover the last one because I don't think that's a policy or authority thing, but just to mention again that there are other approaches to this. So I'm going to focus on the first two, reducing overdetection and reducing overdefinition. So what can we do to reduce overdetection? Okay, I think the problem here fundamentally is what Eric Topol about 20 years ago called the oculostenotic reflex, which is well described in medicine. It's see the stenosis, stent the stenosis. That is, once we see a lesion, doctors and clinicians, and probably even the patients, have a great difficulty in leaving it alone. So the best thing is not to do it in the first place. Don't look. Okay, that's the cure to a lot of overdiagnosis, is never to look for it in the first place. Once you have found it, of course, there's other two things that I talked about, and I'll come back to those. But the first step really is to reduce the amount of looking that we do, or how we look, or how frequent we look. And I'm going to give you a couple of examples of that. Neuroblastoma screening. Pilots were done in the 1970s, and there was a national program started in Japan in 1985. Other countries started to look at that. Interestingly, Germany started pilots in 1991 and Canada about the same time. Very sensibly, they didn't do randomised trials, but they did it with control regions so they could compare the incidence and mortality in those control regions. So what happened as a consequence of this was this increased incidence in Japan, particularly as you can see in the younger ones, under 1 year old. There was a huge incidence increase in overdiagnosis, which is what we would call it now. It wasn't called that then. And there was a consensus meeting held in 1998 because there was some controversy about this, and they concluded there's no evidence for or against, we should just continue as we are. Okay, but then the two studies, the German and the Canadian studies, reported, and that committee met again because they now had evidence that, in fact, there was no impact, no improvement in mortality of neuroblastoma by doing the screening. There was only harm, the harm of overdiagnosis. And interestingly, they stopped. They ceased the program, and almost overnight, our overdiagnosis problem was cured, or the Japanese one was, which could have spread worldwide, by the way. This was also proposed in Australia in one statement. Over a beer, I'll tell you a long story about that. So the lessons from neuroblastoma is, I think the first one is reversal is possible. We can turn some of these epidemics around. The second, though, is to recognise that here it was a fairly small group who actually made the decision. It was a committee of less than a dozen people who actually said, we're going to stop the program and change what happened in a whole country overnight. But the third thing is that evidence helped here. Having the evidence from Canada and Germany actually helped to turn around the epidemic. Okay, South Korea, we've just heard about how it's the #1 place in the world. It's now one of the most common cancers in South Korea. And there's been this steady rise that you saw, and this 15-fold incidence increase with no change in the mortality rate in South Korea. But again, there's hope. A small group of physicians got together and started publicly calling for a cessation of the screening program. And the incidence has now dropped by about a third. So there's still a long way to get down to get back to normal levels. But we have a huge decrease in the number of people being overdiagnosed in Korea. But how they did it was largely through the media. They actually went to television, newspaper, etc. So it was a direct, because there was no official screening policy or program for this. Their route to doing this was to do it through the media and newspapers. So not quite as effective as when you've got a national program and can just pull the switch and the funding on it, but still very effective to turn things around. And then my final example is prostate cancer screening, which we've seen as a problem everywhere, that there's been a rise in the incidence of prostate cancer and overdiagnosis in that. And this is an interesting study which was looking at clinical decision support. So here we're going down to the individual clinical level. And what this showed is the black spots here are when the clinical decision support was turned on. When they call it clinical decision support, it's not very sophisticated. It has a couple of sentences from the US task force saying, don't do it. Okay? So not rocket science here. When it was turned off, though, it went back up. When they turn it back on again, it comes back down. When they turn it off, it goes back up. So it's relatively convincing evidence that the clinical decision support works, but it's not a sustained effect, unfortunately. So the more interesting thing I find in this figure, which wasn't the title of the article, was actually this decline. And we don't know what's causing that decline, so it would be very useful to understand the nature of that, because the clinical decision support helps a bit, but it's temporary. What we need to understand is what at the more cultural, societal level is going on to cause that decline. And there were things like various publications and guidelines, etc., that were coming out during this period, but we don't know, don't fully understand what of that was actually effective. Okay, so reducing overdetection. What policymakers could do is ensure an evidence-based screening policy, as we've seen in Denmark. Congratulations, it's fantastic. Or in places like Canada, where there's a national guideline, and Australia has a relatively national one from the College of GPs. They're not well implemented, though, in any of those countries. It's certainly far from 100% penetrance of those screening guidelines, but at least they have them in place, and I think that's a good start. Second is if there's uncertainties, try to do controlled trials, at least controlled areas if you can't do individual randomised trials, but that information was essential for turning around many of these things, including prostate cancer screening and the neuroblastoma program. And we need both a health technology assessment program and some regulation of new tests as well in this, and I haven't talked in detail about that, but it's closely related to the screening program. Okay, over-definition, which is screening is a big problem. I think over-definition is an even bigger problem because of the ability to blow up the balloon of definitions. And I don't know if you know, but there's a worldwide competition on at the moment to see who can get the largest numbers of people over-diagnosed. So these, I searched Google to put one in 2, 1 in 3, etc. And these were some of the ones I came up with. 1 in 4 people have a mental illness. 1 in 4 kids in Colorado is obese. 1 in 5 have dyslexia. 1 in 10 have polycystic ovary. And 1 in 3 are at increased risk of chronic kidney disease. But over the last few days, I've actually heard about a few 1 in 2s, and I'm sure somebody's going to get a 1 in 1 and get the gold medal for the biggest over-definition area. So how can we stop this? Well, one of the issues is, what's the source of these definitions? So Ray Moynihan, as part of his PhD, did a fantastic study where he looked at the definitions of diseases and who and how changed those definitions, looking at sort of reasonably common or large conditions. And he found that in 16 publications, 14 common conditions, 10 widened and 1 narrowed the definition. I'll point out that that was anemia, which had already broadened it, I think, 7 times in a row, and then eventually contracted it back because of the harms that were being seen. And they widened it through 3 methods: the invention of pre-disease, lowering a specific threshold, or using an earlier or new diagnostic method. But the most common was probably lowering the thresholds. Importantly, none had a rigorous assessment of the potential harms of those proposed changes. And the proportion with conflicts of interest was 75%, and 12 out of the 16 chairs had ties to industry. So I think that's one crucial thing that can change. But there's 2 things implied in this. One is the rules, and the other is the conflicts. So in the conclusion, they said research and policy attention needs to be directed at designing new processes for reviewing disease definitions free of financial conflicts of interest and informed by rigorous analysis of the benefits and harms. It'd be great if that could happen. So I'm going to give you a couple of examples. I'm going to talk about gestational diabetes. This is an interesting map of the changes in the definitions of gestational diabetes since the 1980s. If you want to learn more about it, Christiana Nuchtgeboren is going to talk about this in tomorrow's session at 2 o'clock. I just want to focus on a very recent change in the definition, comparing the WHO and IMD-PSG one. So there's been controversy about some of these proposed changes, and the NIH held a consensus conference to look at the evidence for one of the changes, which would have increased the rates of diagnosis of gestational diabetes from around 6% to about 18%. And they concluded that there was no evidence of improved outcomes. There was some evidence of increased risk for this group, but no evidence of improved outcomes by identifying and treating these women. And so they concluded that they shouldn't actually change things. And one of the problems is whether you've got gestational diabetes depends upon which of these definitions you should look at. So one of the folk involved in the IAD-PSG group, David McIntyre, did up this nice Venn diagram which looks at 4 different definitions, and you can see there isn't much agreement here. That's the 15% who would have been defined as gestational diabetes by all 4 groups. And what we'd like to know about is what happens in all of those other disagreement groups. And the sorts of things we'd like to know are in the checklist that was formed by the Guidelines International Networks Preventing Overdiagnosis group. It's an 8-item checklist that we've developed to say, when you're considering changing the definition of a disease, you should just look at the number of people affected. What was the trigger for it? Why do you want to change the definition? What's the prognosticability in those extra cases, the incremental cases? What's the precision and accuracy of that? Because there's a potential for a lot of misdiagnosis within that. What's the benefit of that group and what's the harms, including labelling the patient with it and worrying about it, but as well as the treatment harms. And then what's the balance of the net benefits and harms? And they're fairly simple things to ask for the evidence for that. And so what we'd like in those, the disagreement groups, the shaded groups, except for this 30% here, would be answers to some of those questions, those incremental groups. Okay, same sort of thing with blood pressure, you know, and we'll hear a bit more about this in the final session tomorrow, is that we all now have high blood pressure, so I think this is now getting to 2 to 1, so they're getting close to the gold medal. This was the proposed change that those previously labelled pre-hypertension would now be labelled as stage 1 hypertension for those with blood pressure between 130 and 139. That would be about 2.3 million people in Australia, 31 million people in the US, and 267 million people in China, and I'm sorry I don't know what the Danish figures are. There's been some pushback on this. One of the things that, if you want to hear more about it, Katie Bell will talk about tomorrow, is using that 8-item checklist to examine the change of that, the proposed change. And they concluded for most adults newly classified as having high blood pressure under those new guidelines, the 80% of those newly diagnosed who have less than 10% risk, there's no incremental benefit in the CVD risk reduction, but potential incremental harms from disease labelling, and for those who meet the threshold for drug treatment from the adverse effects of drugs. Importantly, there was a subgroup within that who might appropriately have been labelled as hypertensive, so there would be some good in that, but a lot of people are going to be very low risk and have a net harm from being treated by these new guidelines. As I say, you'll hear more from Katie tomorrow or in the final afternoon session. Fortunately, a number of groups, very importantly, the American group of family physicians actually specifically rejected the change, which was fantastic. In Europe, the ESC has said we don't accept it either, and recently the International Society for Hypertension has also rejected it. So many other groups have said, we think this is an inappropriate change, which is good to see. We can also redefine cancer too, by the way. There was something in the BMJ last week, I think, saying that we should change the labelling and redefine some things that are so low risk that they don't actually behave what we would expect to be cancer. So let's try and do that. That's happened recently with thyroid cancers. The name was changed from encapsulated follicular variant of papillary thyroid carcinoma to the much more benign sounding, non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which patients find a lot less worrying. But it doesn't have the word carcinoma or cancer, which they do recognise, and so it isn't called cancer anymore. That's great. But that would only be about 1/6 of those cases, so it wouldn't take care of the problem that we've heard about by the last speaker. So most of the cases of overdiagnosis would not be cured by this change, but still 1/6 reduction is pretty good just by changing the labelling. Okay, who should redefine the disease? So we talked about having no conflicts of interest and using the checklist, but the other thing is about who should be on the panels, and Alan Francis, who is the chair of the DSM-4, and he's sitting just over the corner here, suggested that psychiatric diagnosis is simply too important to be left exclusively in the hands of psychiatrists. I agree. All mental health disciplines need representation, not just psychiatrists, but also psychologists, counsellors, social workers and nurses. The broader consequences of change should be vetted by epidemiologists who can help you with that checklist, health economists and public policy and forensic experts, and perhaps even a few GPs like me might be in there as well. And I think that's important, that you need a broad spectrum of people. The biggest problem, I think, with a lot of the changes of diagnosis is where a specialty group with their pet disease want to expand the boundaries. And we need broader input for people who deal with some of the consequences of that change that the specialist groups don't even see. Okay, so summary of the overdefinition. Expanding definitions is a key driver of overdiagnosis, and most of that comes from guideline committees, not things like the ICD, for example. And usually done with no clear rules about how to change that. So policymakers could ask, as they do now for grading of evidence, they should say, use the 8-item checklist, and we're not going to look at it even as a definition change unless you have a required multidisciplinary committee with limited or no conflicts of interest. And maybe we can add a 0 then to many of these, so it's only 1 in 40 people who have mental health problems and only 1 in 40 kids are obese, etc., and that would be great. So, in summary, the things you can do to reduce overdiagnosis, try and stop the tests is the first thing. Inappropriate tests. Tests are fantastic. I use them all the time as a GP, but many of them lead to overdiagnosis and we need to stop those. And then we need to change our definitions as well, and using the checklist and mixed committees, etc. And medicalisation, I'll discuss it another time. Thank you very much.
Thank you very much, Paul. So if I could ask the three panellists, Soren, Salvatore and Paul, and while they're getting seated, could you just turn to your neighbour and just talk about what you've heard, and then I'll come back to you. A minute, talk.